I want to start by thanking Erica and Dylan so much for setting me up and highlighting how critical newborn screening remains as a public health initiative, and the idea that we really need to reshape this program to better meet the needs and desires of the public and the rare disease community. And so for my time today, I want to hone in on two key pieces. So I want to walk us through why we are finding ourselves as a newborn screening community at this inflection point and this need to evolve. And then from there, I want to highlight a couple of national solutions that we're currently working on to try to address some of these needs to evolve the newborn screening system. So you heard from Erica that newborn screening is not new. In fact, we've been at it since the 1960s, and despite my hilariously poor ability to guess people's ages, I'm venturing most of you in this room have had newborn screening in some way. So we started in the 60s with one disease, as Erica mentioned, phenylketonuria, or PKU. And now today we have 36 diseases that are screened through that dried blood spot matrix. And that results in more than 1 in 500 children being affected and helped through newborn screening. And this evolution and expansion shows no sign of slowing down. So this shows on the graph here on the right the predicted increase of disorders that may be detected by newborn screening. We see the disorders on the right and the affected, impacted babies on the left. The bottom line here is that we expect a significant number of new diseases to make sense for screening, to become eligible and meet the criteria that Dylan outlined for newborn screening. And at the same time, I think many of us in this room are well aware of the idea that the current system does not have the capacity to keep up with this, whether it is workforce, whether it is limited public health resources, competing priorities, poor data integration, or poor care coordination. This is going to be a problem for us if we don't really change the way we're looking at newborn screening in this country. So I chose this really easy to read graph to impress upon us the reason why we're likely to see this expansion in newborn screening. Historically, we've been limited for newborn screening because of our laboratory techniques and our, the technologies that we needed to screen for these disorders. That's really not the case anymore. And so what is driving expansion is therapeutic availability. And this image shows current gene and cellular therapies either in pilot phases or clinical trials or marketed, many of which are for rare diseases. And so you can take a look at this graph and pretty easily think about, as therapies become available, we probably should start thinking about screening for these in order to allow for early detection and the pre-symptomatic treatment that Erica mentioned is so important for rare diseases. So understanding that we are likely to see this explosive growth in newborn screening, there was a study out of RTI International in North Carolina that called for a modernization of the newborn screening system. And through this study and listening to a variety of perspectives across the ecosystem, they identified 5 domains for modernization. Dylan has touched on a few of them in terms of the first, the reviewing and improving timeliness of RUSP review in addition. Creating mechanisms to offer screening for disorders in addition to those on the RUSP, so maybe those that haven't yet had the opportunity to go through that process. Accelerating and expanding data collection to inform policy decisions and implementation. Helping states expedite comprehensive implementation of newborn screening for new disorders. And then evaluating emerging methods of screening and their consequences. This is largely focused on the idea of genomic sequencing in newborns. But for today, I'm going to focus on these 2 areas of modernization. So why is this idea of needing accelerated and improved data collection so important in newborn screening and truly in rare disease for that matter? So I've taken the kind of answer to that question and put it into 6 topics. So the first is it's really important for us to understand these diseases, to have the data to understand what's going on in these diseases, the natural history of these diseases. Are we improving outcomes because we're picking them up earlier, because we're implementing pre-symptomatic treatment and management? For newborn screening, because these diseases are rare, it's unlikely that any single state will ever generate enough data to really answer that question. So we have to think about de-siloing data collection around newborn screening. Understanding the disease, I'm going to hop around this graphic a little bit, ultimately helps us then improve our therapies and management as well. If we understand the natural history mechanisms of the disease, we can better work towards precision medicine and personalized medicine in the advancement of targeted therapies and management. But ultimately, when we think about why we need better data in rare disease and newborn screening, it really comes down to just supporting these babies and families that we have put into this system. And that can be through things like informing policy. I'm a strong believer that we cannot address things that we don't assess. We can't try to address gaps that we don't know exist. And so collecting data in understanding where there are gaps in either the screening effectiveness, access to treatment, education, that will help us then drive the policies that we need to support this public health program. It can also help us improve support systems for these individuals, whether that's financial support systems or even the psychosocial support. Erica mentioned the word trauma, and that is something that we hear a lot in the rare disease community, and it is a huge gap in care around mental health and trauma-informed care. And also improving transparency and patient engagement in the program as well, understanding that data can be used to make things better, not only for you as a family, but for other families going through something similar. In terms of trying to expedite comprehensive implementation of newborn screening, and I think Dylan highlighted this very nicely, that despite the fact that we have a recommended uniform screening panel, we still see a lot of variations state to state. And why is that? Some of it is because we have legislative additions, so sometimes advocates will go directly to their state legislature to add diseases for a variety of reasons. Sometimes they don't want to wait for that lengthy process that Dylan mentioned. The problem with these often is that they are unfunded mandates, and so that can be difficult for programs then to continue with their RUSP implementation with the lack of resources. But ultimately, I think the biggest thing is that we are a public health program, and so newborn screening falls trapped to being part of public health. And so there are variations across states in their ability to add diseases at the state level, hire people to do the testing, have specialists to see these patients. And so this is a big problem that we really need to think about how we can take what has historically been a state-based system and start to coordinate and unite it a little bit more. So I want to now end with my last couple of minutes to talk about some solutions that are going on, particularly with the CDC and their newborn screening molecular biology branch around those two topics. So the first is the data issue. So we are working on a national newborn screening data platform called EDEN. EDEN stands for Enhancing Data-Driven Disease Detection in Newborns. And the idea behind this is to use de-identified data across all of the programs, start applying some of those AI machine learning aspects that Senator Klobuchar mentioned to better provide the ability for us to understand these diseases, have better risk assessment, reduce false positives, mitigate false negatives, and all in this idea that the experience will be improved for the families, and our risk assessment will be more standardized from state to state. So this is a long project that group will be working on for some time, but really a novel idea of finally starting to aggregate and learn from all of this data that newborn screening programs are generating. Also looking at the creation of so-called centers for excellence. So this is a model we see in rare disease pretty often. We see it in public health as well. And this idea is that there would be centers where programs who maybe don't have the resources or need assistance to add diseases can go to help expedite or even maybe do some of the screening for them. So the idea would be providing technical and training support, regulatory assistance. You heard the word LDT, laboratory developed tests. This is a big issue for us in newborn screening. Like many rare diseases, we use LDTs. You'll hear more about that from the next speaker. Providing higher complexity testing, like genomics, et cetera. So this is a new model that the community is looking at to try to address some of these disparities we're seeing state to state. And so I'll end that by saying really the future of newborn screening needs to start now, and it needs to start with really big solutions. One of the, I think, most beautiful things about newborn screening, as well as the most challenging things, is that it is this intersection of people, science, and policy. And that will continue to be the case, but we really need to evolve, adapt, and innovate because we have some significant issues that we need to address to meet the needs of this very large rare disease community. So thank you.